Good morning, everyone. So like I mentioned earlier, I'm Dr. Maynard. I work at UC Davis Medical Center, and I'm a physician there in the emergency department. I'm an EMS fellow as well, and so that's what brings me here. And today we're going to be talking about psychiatric emergencies in the pre-hospital setting and really focusing on one condition in particular that you really need to be aware of and that you know how to handle, and guaranteed you're going to be faced with it not infrequently. So I like to start off with a case. So this first case is a 45-year-old guy. He's in police custody. He's hallucinating and agitated. So he's outside the convenience store. He's yelling, shaking his head. Looks like he's hallucinating. People are trying to help him, but he's resisting any type of aid. So PD are on scene. So after the initial struggle with the police, he escapes, and he's just running around the parking lot, and by this time, EMS arrives on scene. So they get to the guy, they put him in manual restraints, they strap him down to the gurney in a supine position, and they get him in the back of the ambulance. The medics on this particular case, this is a real case, this went to court. So he's, they say that his vital signs were unable to be obtained. And the medics note on their physical assessment part that there was no overt signs of trauma, and that his pupils were mid-range and reactive, skin was warm and dry, and that he's obviously awake and alert. And sometime during the transport, the patient suddenly goes completely unresponsive. So the medics recognize that he doesn't have a pulse. They start CPR, and this is all happening right as they were arriving to the emergency department. And on the monitor, they note that he's in asystole. So, like I mentioned, they start CPR. They get in the supraglottic airway. They give him some epi and some glucose, and they get him into the emergency department. While in the ED, they note that his pupils are dilated, non-reactive. They switch the combi tube out for a ET tube, and they keep going with their ACLS. And after 22 minutes of resuscitation, the patient's pronounced dead. So what do you think happened in this case? There's a lot of things that could have happened, but this is a case of agitated delirium or excited delirium. And so if you ever run on a psych patient, any of you who've been out there working in the field, you ever been on a patient like this before? They're hallucinating and you needed to restrain. And they can be really challenging. And so we'll talk about what this condition is and why you need to be aware of, know how to handle it quickly. So here's a really great video to highlight a patient in agitated delirium. So this is a video that was published by Fort Worth Fire Department as part of their EMS training. And so I'll kind of skip through a little bit and highlight a few things as we go forward.
What's up, buddy?
White male, no shirt, approximate exposure pants.
It bugged me. Lay down. Lay down. What's going on, bro?
They beat me up.
Who? How much coke you smoke, man?
I don't do nothing. Oh, Lord.
Hey, do me a favor.
What?
Relax.
Please.
Okay? I'll help you.
Oh, my God.
Hey, relax.
I want nothing lower now. I'm sorry.
Relax. Get on the ground. Get on the ground. Get on the ground.
I'm on the ground. Oh,
Stay
Lord.
there. Hey, stay.
So I think at this point, the officer needs to really recognize that this person doesn't appear to be in the act of committing any specific crime, that he is not in the right frame of mind, and that this is likely a medical situation and should alert EMS personnel to be on their way.
Like that. Come here, dude.
Oh, I'm right here. Ow.
Stop.
Oh, man.
Hold on. The cars are gonna. Oh, the fuck. Come here, dude. Come here. Come here. Come here. Come here. Come here. Come here. Come here.
I'm sorry.
Put your hands behind your back. Put your hands behind your back. Put your hands behind your back. Put your hands behind your back, dummy. Put your hands behind your back. Now. Put your hands behind your back.
Just sit, brother. Just sit. Just relax. Relax. Just relax.
Relax.
Okay, just relax.
Leave me alone, please. No, I got balloons. I got balloons.
I got his hands. I got both of them.
What do I do?
You got one? I got you.
Channel 1, 667, channel 1.
Don't start the medics.
Start medics with both floors.
So I think they do a really good job there. You know, they've recognized now that this is a medical situation. They've got the medics on the way. I'm just gonna skip forward just a little bit.
Get him. Sit him up. Sit him up. Sit up. You're a fucking dummy.
Just leave.
Sit up.
I love you, Mr. Lewis. It's me, dying, Lewis. Oh, the cops are killing me. Just shut off. Help me.
Yeah.
They've got the patient hobble restraints now, and the shift supervisor is now on scene.
Can't get him up, then I'm gonna do a drive.
Why are you trying to kill me?
Hey, you need to chill out and sit up.
Leave me alone.
Sit up on your butt, man.
Why? Who are you, officer?
I'll start the medics here.
You already did. Hey, look at me.
As you can see now, the patient's gone unresponsive.
Checking for pulse, make sure he's breathing. Undo the hobble if you have to.
I'm
Let's
trying
get this
to, but I
guy
can't get it.
back going again.
He's got a pulse.
Okay. All right, he's probably going to stay unconscious, so let's go ahead and undo the hobble. If we have to hobble again, the hobble again. You all right?
I need a light. I got it. Here it is. Get him up on it. Sit him up. Get him up. All the way.
Yeah, Rick, take that hobble and hold on to that hobble. Right, got it?
So now they're going to try and provide some back valve mask ventilations to this guy. He looks pretty out of it. Be very surprised if he had a pulse at this point. Is likely in cardiac arrest.
Making it, yes.
Now they've started chest compressions.
5 and 2.
3,
5 and 2.
And so I'll stop it there. But you know, this patient, he didn't survive. He ended up dying as a result of this. And so this is what we are so afraid of with these patients in agitated delirium. And so we'll talk about a little bit later, like why this happens and what you can do to help prevent it. Excited delirium, it's also known as agitated delirium. It's a little bit of a controversial diagnosis. And so there's the DSM-5, what I mentioned there. It's a manual that was created to establish a set of diagnostic criteria for a set of mental health disorders. And so it's agitated delirium and excited delirium is nowhere to be found in the DSM manual. Also, this ICD code is coding that we use in the hospital for different diagnoses. So when we diagnose with a patient, it's established with a billing code, and there's no official billing code for excited delirium, agitated delirium. So but it has been recognized by ACEP, or the American College of Emergency Physicians, in 2009 as a problem, and so as emergency physicians, we recognize that this is an issue and have established it as something we need to be aware of and manage. So it's a true medical emergency, and that's, I think, the biggest point I want to hammer home with you guys is this is a true medical emergency. You don't want to just think about it as like an isolated psychiatric issue. This is a medical emergency, and there's a high risk of death associated with this condition. And so these are really dangerous situations. They're dangerous for you, they're dangerous for the patient, they're dangerous for law enforcement. So we need to be really vigilant and know how to handle it. And the cases are often high profile. You can think even recently in the media how many similar types of cases where someone died in police custody has made major news. And so just to keep that in mind, that when bad outcomes happen, sometimes they hit the news, and when they do, they're really high profile, and there's a lot of scrutiny around these situations. So the clinical features of excited delirium, it's really a triad of delirium, so they're not in their right state of mind, psychomotor agitation, and physiological excitation. So they're really, agitated, moving around, difficult to control, and their heart rates and blood pressures are really high. So as you can imagine, it's associated with drug use, is common, and common players here, cocaine, amphetamines, also has an association with mental health illness, but not always. And typically it's males in their 30s and has a high risk of cardiopulmonary arrest. And just to remember that when you have a patient like this, it's not to just get tunnel visioned and think in your head that it's only a psych thing or a drug thing or a psych drug thing, that there are other causes for someone to be acting like this. Like these are other medical conditions that you need to just have in the back of your head, and make sure you're running through in what you're thinking about could be going on with this person. So, could they be hypoxic? Could their blood sugar be low? Could they have any, intracranial injuries? Does it look like they have any trauma? Are there any signs of infection anywhere? So this is like kind of we call this a differential diagnosis, or just a set of things that it could be, that you guys just should think in the back of your head and not get so tunnel visioned into just thinking it's one thing and one thing only. So keep your mind open. So we'll talk about our the approach of what we'll discuss going forward. So these situations, they need to be brought under control quickly, like I've mentioned many times, to ensure your safety, the patient's safety, and to allow us to start the medical workup so that we can rule out the other things like the infection, the major trauma. You can't do an assessment on a patient who's thrashing around and going crazy. We're going to talk about verbal de-escalation. We're going to talk about physical restraints. We're going to talk about pharmacological sedation. And we're going to talk about assessment, monitoring, and documentation considerations. So the documentation considerations I have in this presentation are taken straight from the county protocols. And then just a few other loose ties. And then I want to go over as well some of the precipitating factors for why these patients go into sudden cardiac arrest. All right, so verbal de-escalation. So sometimes it's not possible. The patient's just too agitated and too much of a danger to the public and to themselves that you just got to get in there and bring the situation under control. But we should be thinking in these cases that that's our initial step, is trying to verbally bring these people down. And so some of the things to just keep in mind when you're talking to these patients is just to provide them with some space. Don't crowd them out. Give them some 2 arms lengths distance at least. Make sure to keep your hands visible and stand at an angle. And it's kind of weird if you think about standing at an angle, but oftentimes when someone's standing straight on to you, it appears somewhat confrontational. And so that's one thing that they talk about in managing this, is just to do everything we can to appear as unconfrontational as possible. Make sure that you are aware of your surroundings and your scene safety. Never allow your exit to be blocked when you're in the house. And I ran a call recently with a crew where we got called out to a guy with a known psychiatric disorder. He's upstairs. His mom called, and she called because he's just hasn't been taking his meds and he's been throwing stuff and yelling. So she got scared and she called us, and we get there, And this is a little duplex, and you open the front door and there's a narrow walkway that goes upstairs. All the lights are off in the house, completely dark upstairs, and my medic opens the door and walks straight upstairs with nobody else behind him, by himself, up in this top floor where the patient's at. We don't know where he's at. We don't know what he has, and it made me very uneasy to just watch him walk up there by himself alone with nobody else. So we talked about that a little bit, but just make sure that you keep your surroundings and your safety in mind. Make sure that you introduce yourself. Make sure you keep your language simple, and as much as your vocabulary is much higher, especially in the medical world, than the average public. And so just keep that in mind. Try not to use big words. Just use simple terminology to explain things. And then just a few strategies to keep in mind that sometimes work is, one of those is just ask the patient if there's something they need. And I hadn't really thought of this too much, and I had a conversation with a colleague, and this is something that they did, and it really worked on a patient I didn't think it would work on. And so I've started to use that more and more in the hospital. It's like, hey man, can I get you some juice or some crackers or a blanket? And like, surprisingly, it's been helpful in a number of cases. So just a tool in the toolbox you can think about. Just remind them that at the hospital we have food and we have blankets and we're there to help out. And maybe that's all they're looking for, some place warm to sleep or whatever. Just something to think about. And then just make sure they know that you're there to help. You want to offer them choices when possible, but make sure to set some boundaries. And then just do whatever you can to not appear threatening to these patients. And so we're not going to try and avoid threatening them. If you don't get on the gurney and come with us to the hospital, we're going to strap you down and drug you up. It's kind of not use such harsh language if we can avoid it with those patients. So try not to threaten them with restraints or anything else. So physical restraints, just remember that this is a team sport. You're not going to go it alone. It's not going to be just you and your partner. If ideally you want to gather all the equipment and medications beforehand, because that's going to really help. You want to coordinate your efforts, like what everyone's going to do. So if you can and you have time, make sure you spend the time to get all your stuff together and discuss the plan with everybody around. And you guys are going to be running on calls there's going to be 1 million people on the call. You're going to have you and your partner, and you're going to have an engine crew. So there's going to be plenty of people on scene, the majority of the time to help you out. And ideally, physical restraints should be placed at the same time as chemical sedation. So we want to use the least invasive means of bringing someone down as possible, which I think we really want to make stress to start with verbal de-escalation. But if the patient's progressing to the point where that you need to really get them restrained, I want to just caution against 2 and 3 point restraints. Sometimes people will come in with just their arms on the gurney, and these restraints are less secure and actually end up being more dangerous for you and for the patient, especially on a gurney, because your legs have a lot of power in them, and when your arms are just strapped down, patients can flip that gurney if they want, and they can turn around and kick you. So if you're going to be restraining the arms, restrain the legs as well. 4 point restraints is much more secure, and that's what we do in the hospital. Now, if you have like the other day, I ran a call with it was a 96-year-old lady who weighed 80 pounds, maybe, tiny, and was delirious and just yelling at her son. She just needed a seatbelt, and that kept her in. So that was a chance where that was the least invasive method, and it worked great. But a big guy, like a 6-foot guy, 200 plus pounds, who's agitated and combative in any way, 4 point restraints. And we want to take the fight out of these people as fast as we can. So the restraints is going to help, protect them and protect us as well. But the longer they're fighting and the more they're agitated, and I'll talk about this a little bit more in detail in just a sec, the higher chance for badness to happen. And so a lot of the teaching is that if we're going to do physical restraints, you should back that up immediately with chemical sedation. You want to bring the situation down and bring the patient under control as fast as you can. And that's the strategy that we employ in the hospital. I'm never giving somebody just 4-point restraints and nothing else. They're getting 4-point restraints and chemical sedation. I'm not going to allow this patient to just continue to thrash in bed. And then make sure when you're securing the restraints that you're doing it to fix positions on the gurney. So there's a number of different ways of doing this, but I just encourage you when you get on shift or when you're looking at the cot, just identify the positions of like, where am I going to secure the arm restraint if I need to? And just have those positions set up in your mind so that you can go right to it when you need to restrain the patient. Restraining them to the side rail that goes up and down is not acceptable. And then also the headrest that goes up and down, those are movable things, and they're less secure, and so it needs to be to hard fixed positions on the gurney. And avoid the prone or hobble restraints. And so the reason is because when they're in that position, they're not able to take a full breath in and out, and so you're inhibiting their ventilatory ability. So those positions in many counties across the state and in states in the country, restraining patients in those positions is prohibited. But it's not outright prohibited here, and it's, I'd say, frowned upon here in Sacramento County. But we should not be putting any patients in that type of a restraint. But if law enforcement put the patient in a hobble restraint and they're being transported that way, the protocol states that you need to monitor the patient every 3 minutes or reevaluate the patient every 3 minutes. And then sandwiching the patient between the backboards is prohibited. Anyone ever seen that technique? Yeah, in my first day in my EMT school, that's how we were trained on that. You had 2 people walking towards the person with the backboard.
But I had a quick question for you, Doc. Yeah. You said not to restrain to the part of the head that raises.
If you can avoid it, yeah.
Are we no longer doing high-low?
I don't love high-low. I know that's kind of a preference thing for medics to do that. And the reason I don't like it is because I feel like they do have a harder time taking that deep breath when they're like this, especially when you have them really tight.
They're more controllable when they're high-low ambulance. If you go low on all restraints,
right,
they just pull themselves right down the gurney.
I know, that's the trade-off for it. So that's a preference thing. I think high-low, I have no issue with people putting them in high-low. I see it all the time. But like in the hospital, we're not putting people in high-low. We're putting people like this. We're just making sure that they're secured really good. I know. I get the point. I get the point for sure. So if you want to do it this way, it's fine. Just make sure that there's no way that little red handle is going to be hit or anything like that, because that's going to move the gurney. So just however you're going to rig up your restraint, just make sure it's away from anything red.
And trapped, it can't slide on the rail.
Yeah, exactly. And in trapped, so it's not going to slide down up or down the rail. All right. So patients in law enforcement custody. So if the patient's in law enforcement custody, you need to make sure whatever restraining device they're in, that device allows the patient to straighten their abdomen and chest and be able to take a full breath. And so that's up to you and your assessment of the patient to just make sure that whatever restraint they're in, that you're coordinating with your law enforcement officer to make sure that their ventilation is not inhibited in any way. And like I say, all of this stuff that I'm talking about and not inhibiting their ventilation is just to prevent the sudden cardiac arrest that we see in these patients. So that's why we're doing all this stuff, is because we're trying to keep the patient safe as well. And so when patients are in the restraint device, the officer should always be with the patient if possible. So the ideal situation is the officer comes with you and that they have direct access to the key. Sometimes that's not always possible for the officer to be with you at all times, and I would say that if the officer is not going to be in the back of the ambulance with the patient, they need to be following you, and you need to have coordinated a plan where if there's an issue, you can let the officer know immediately. So however you want to coordinate that with PD, you can do that, but you need to have a way of alerting the officer that you need their assistance. So before you start transport, to talk about that, and that you, as the providers of this patient, need to have a way of immediately releasing the patient from the restraints at all times. So to me, I interpret that as that, if you're transporting a patient with the handcuffs on, you need to have that key so you can get them out of the handcuffs immediately. So just a few things to keep in mind with law enforcement, patients in law enforcement custody. Any questions on that? Okay. So this is that's a hobble restraint, so don't do that. And this is a patient in prone position, so don't do that. This is the protocol for the county for chemical sedation. It's a little interesting of a protocol. I would say that this, for IV route and intranasal route, if the patient happens to have an IV, great. But that's going to be unlikely. So don't waste your time trying to get an IV on this agitated patient who's trying to punch you in the face. Just go for IM. That would be my recommendation. And if you want to do the typical is like 5 milligrams IM, but if 5 to 6 milligrams IM just straight up is great. Intranasal route, when this person's thrashing their head and they're probably all snotty from the fight, that's not going to work great for you. And the thing I don't like about it too is if your max dose is 6 milligrams for all routes. So say you gave happen to give 3 milligrams or whatever you want to do intranasally, it doesn't leave you much room to give it any other way if that's not working. So my suggestion is just to go straight for intramuscular route just right from the beginning. Okay, and this is your documentation requirements. So you need to make sure after you've got this patient restrained and sedated, do a good physical exam. Look for any injuries. Make sure that the patient is on the monitor. They're getting continuous ECG monitoring and continuous SAT monitoring. Check their blood glucose. And then in your documentation, you have to document these things. So document the patient's mental status, vital signs, extremity exam of all the restrained extremities, and you have to do that every 5 minutes, or show that you've done that every 5 minutes. You have to document their lack of response to verbal controls, or say the patient was so agitated that you couldn't do verbal controls, why that was the case. So you have to address it somehow of addressing that you tried or at least thought about trying, or why you couldn't do verbal controls. So you need to include that in your note. Obviously, the need for restraint, any injuries that the patient had, any injuries that EMS personnel or any other personnel on scene sustained as a result of the restraining efforts, the need for continued restraints, and obviously the method for restraining the patient and the method that you monitored them with. Okay, so other considerations is to give a pre-arrival notification to the hospital. Let them know that you are coming in with an agitated patient who's in restraints, and kind of paint that picture, because when you get there, they're going to be ready. They're going to have their security officers standing by that are going to be ready to transition this patient from your gurney to the hospital gurney. And it's going to save a lot of time, and the hospital is really going to appreciate it when they have a little bit of heads up. So make sure that you give them notification of that. Late-term pregnancy, make sure that you transport the patients in the left lateral position. You know why that is? Why would we want to do that if we can? Anybody? There you go. Right. So that big gravid uterus is going to be compressing on the inferior vena cava. Right. It's going to reduce blood flow. So make sure that you transport them onto their left lateral side. So some predisposing factors for why patients may go into sudden cardiac arrest. Like, why does this happen? So if you think about it, they're fighting like crazy, and when they're say I pointed out a few times, you know, they're in restraints. People are maybe standing on their chest, trying to get them, you know, under control. So their ventilation is impaired. So their CO2, they're not able to blow off their carbon dioxide, and they're not able to take a good breath in. So they're becoming hypoxic and hypercarbic. And what that's doing is that's lowering their blood pH. So they're becoming more and more acidotic. So our blood pH is a very narrow range. So 7.35 to 7.45. So it's a narrow range. So when it dips low, and things that make it go low are increased CO2 and then increased lactate. The more they're fighting and fighting and fighting, their muscles are getting fatigued. They're building up more lactic acid in their blood, and that is also contributing to this severe acidosis. When the muscles break, so skeletal muscles, when they're fighting and they're tearing muscles, even on a small scale, there's more potassium inside a cell than outside the cell, and that potassium gets released into the blood. So they're becoming more and more hyperkalemic. And our hearts do not like hyperkalemia at all. They're getting rhabdomyolysis, so that's going to really affect their kidneys. They're getting hyperthermic. And imagine adding all that stuff on. So hypoxia, hypercarbia, acidosis, hyperkalemia, add all those things onto someone who's got a bad heart from doing 20 years of meth. Someone who's got a coronary artery in their heart that's maybe 80% narrowed, and all the demands that are now on that poor functioning heart. So all these things can set this patient up for spontaneously going into sudden cardiac arrest. And I don't think there's one, that's why it's a hard diagnosis for agitated delirium to make, is because there's not one unifying reason for why this happens to patients. It's a multifactorial, and there's a number of different things that go into it. But when these patients go into cardiac arrest, the outcomes are extremely poor. We do not get these patients back. It's really, really rare. And so oftentimes when they go into cardiac arrest, they die. So we want to do everything that we can to prevent that, and that's going to be making sure our restraint technique is good and making sure we bring the situation under control quickly. But we say we've done everything we can as best we can in the situation. Sometimes bad outcomes are going to happen, no matter who you are. And so this is a doctor who's pretty famous in the medical education world for emergency medicine. And when he was speaking on this topic, he said, be aware, be afraid, but don't beat yourself up if this happens to you. We just want to make sure that we're doing everything we can to prevent it from happening. But if it does, we're going to do our best to treat that patient. So I'll just go, and we'll end here on a good note where I think, let's see, can you hear that?
An onlooker's cell phone has once again captured a tense encounter between police and the citizens they are sworn to protect. But this one ended not in death, but in applause and a man heading to the hospital. Saturday afternoon, a man was naked, rolling around in the street, not making any sense. Officers recognized the guy's actions were more of a medical emergency than criminal activity and took special precautions to get him help. In a story you'll see only on KXOI4, Jeff Humphrey joins us now live at Broadway and Elm, where neighbors got an eyeful but also applauded police for their efforts. Jeff?
Nadine, like some of our police activities, this particular standoff went long enough for neighbors to record some of it on their cell phones. From his vantage point, Benjamin Blazevich, he wasn't sure what was about to happen, so he had his camera rolling just in case.
I'm leaving.
It was the sound of this man's screams that brought Benjamin Blazevich and his friend Nick to the end of this Broadway Avenue alley.
Well, at first it was kind of a shock when I walk around the corner and there's a naked dude screaming a bunch of random stuff.
Because of recent critical incident training, Sergeant Tony Giannetto knew the man was suffering from excited delirium and first called for paramedics.
And then we noticed all the cops started showing up. Yeah, and then he's flopping in the street doing his naked thing.
By then, the sergeant already told dispatchers he would need at least 4 officers to contain but not crowd their subject.
We recognize that excited delirium is a medical issue, and it is not as if we were chasing a fleeing bank robber or some crime in progress. So our main concern is to make sure the person stays safe and that they don't present a danger to anybody else.
Keeping an excited delirium patient calm includes not using lights and sirens at the scene. The man obviously wasn't armed, and so police kept all of their tools in their holsters.
Nobody had anything drawn on him. They were all just kind of standing around, and then he got up and tried to run, I guess you could say, and then the cop just kind of grabbed him, and then everybody just swarmed him.
Excited delirium patients have racing heartbeats and rapidly overheating bodies. Taking the precaution of staging paramedics nearby dramatically sped up this man getting the medical treatment he needed.
Is it really true some of the neighbors clap?
Yes, I was actually one of them, and I said, "Good job, Spokane, man.
Good job, Spokane.
You did a good job."
So I think that's just a good example where, you know, the officers clearly early on recognized that it was a medical problem, and their incident training helped them to address the situation in a calm way, and EMS was able to be coordinated with EMS well and got the patient to the hospital safely. So that's all I got for you guys.
Class 21-1, Hudson, Hut! Thank you, doctor, thank you.
Thank you, doctor, thank you.
You're welcome.